security operation.
Tax reforms bills pass second reading in Senate.
These bills aim to simplify the tax landscape.
Cheaper rides ahead. Federal government launches commercial CNG buses in Abuja.
Which will ensure that Nigerians can access clean, more affordable energy solutions.
And on Good Morning Nigeria today, we shall discuss sustaining the fight against HIV and AIDS.
All right, the global fight against HIV and AIDS has come a long way, but the journey isn't over yet. The World Health Organization has set an ambitious goal to end AIDS as a public health threat by 2030.
Absolutely, Victor. Together, the targets are clear. A 90% reduction in new HIV infections and AIDS-related deaths between 2010 and 2030. Big goals, you might say, but achievable with the right steps.
And speaking of numbers, here's a sobering reality check. Globally, around 38 million people are living with HIV and AIDS. Just in 2020, 1.5 million new infections were recorded. And sadly, 690,000 lives were lost. You heard me, 690,000 to AIDS-related illnesses.
Not a good one. And here at home, Nigeria ranks 4th in the world for HIV burden. About 1.8 million Nigerians are living with HIV, making the country with the highest HIV prevalence in West and Central Africa.
Now, the good news is that Nigeria is pushing forward with the UNAIDS 90-90-90 targets. The aim is that by 2025, 90% of people living with HIV will know their status. 90% of those diagnosed will be on treatment, and 90% of those on treatment will achieve viral suppression.
Still, we've got some hurdles. The prevalence rate among adults aged 15 to 49 is about 1.4%, and in 2020, we recorded around 52,000 new infections. Progress is happening, but the challenges remain real.
And that's why we're here today, raising awareness, improving access to care, and fighting the stigma are critical. Welcome to Good Morning Nigeria. Today we go full throttle into the progress, challenges, and future of Nigeria's HIV and AIDS response.
And as the country works towards hitting the UNAIDS 95-95-95 targets and ultimately ending the epidemic by 2030, we will unpack the strategies and innovations driving this mission.
It's a conversation we all need to engage in, and we are up for it. I am Victor Azu.
And I'm Nigerian. John. Many thanks for joining us. You're watching Good Morning Nigeria live on the network service of the NTA. In the course of the program, Chukwudi Okoli-Ugbaja will join us for newspaper review. But for now, let's pause at this point and let the beautiful Ogo Chukwuka Ona lead us with the morning news. Good morning to you, Ogo.
Thank you, Ian and Victor. Here is the morning news. President Bola Tinubu is nudging France to see and treat Nigeria as a serious strategic partner to ensure proper development across Africa. This was during his engagements on a state visit to France in honor of President Emmanuel Macron's invitation. President Tinubu and his wife, Oluremi, were accorded a grand reception in Paris.
Don't take Nigeria for a serious country and a partner in your crusade. You won't achieve the results. Nigeria is ready to partner with a friend
With the President and his ministers, we have defined several new lines of actions for investment of French companies in Nigeria, of course, in the energy sector.
The 4 tax reform bills have scaled second reading at the Senate. The proposed tax-related legislations are the Nigeria Tax Administration Bill, the Nigeria Revenue Service Establishment Bill, the Joint Revenue Board of Nigeria Establishment Bill, and Nigeria Tax Bill. Leading debates on the general principles, Senate leader Opeyemi Bamidele says the proposed bills seek uniformity and efficiency in tax system in Nigeria.
Adequate sensitization.
All the gray areas and areas of concern by Nigerians and some concerned citizens should be addressed appropriately at that level.
And now the House of Representatives has resolved to continue consultations on the 4 tax reform bills presented by President Bola Tinubu to Parliament. This resolution followed more than 2 hours of closed-door deliberation on the issues by lawmakers. The House also confirmed the appointment of Lieutenant General Olufemi Oluyede as substantive Chief of Army Staff.
Section was to continue our conversation. So this conversation is going to continue on Tuesday, from now till Tuesday, when we will have a special section where we'll invite these resource persons to be here in the House to engage us.
Nigerians will begin to enjoy subsidized transportation across major areas within the Federal Capital Territory as the federal government officially launches and hands over CNG buses to operators for commercial purposes.
To ease the burden of fuel subsidy removal, which will ensure that Nigerians can access clean, more affordable energy solutions that reduce transport costs for operators and commuters alike.
I would like to use this opportunity to appreciate President Bola Ahmed Tinubu for this initiative.
And now the annual Symposium of Heads of Navies is underway in Abuja to discuss key issues in the maritime domain. Declaring the symposium open, President Bola Tinubu, in a message delivered by the National Security Advisor, pledged continuous support for Nigerian Navy operations and objectives to enhance security in the Gulf of Guinea, which drives the economies of more than 25 African countries.
Because another step forward in the achievement of our common objective of a peaceful, secure maritime environment.
Through shared responsibilities and concerted efforts, we can effectively combat illegal activities at sea and unlock the immense economic opportunities our oceans and waterways offer.
And those are the highlights of the news at this time. Good Morning Nigeria continues with Victor and Ian.
Mortibet sponsors coverage of the English Premier League.
All right, thanks for staying with us. And this is Good Morning Nigeria on the network service of the NTA. Up next is Newspaper Review.
All right, let's take a look at what the papers are saying this morning. We'll take a look at the headlines quickly. We'll begin with the Guardian newspaper this morning, and it leads with World AIDS Day. That's the kicker. And it says rising spread, more HIV infected kids, slow race to zero scourge. That's the lead story here. And of course, there's a breakdown of the statistics on the front page here. It says about 140,000 Nigerian children are currently infected by HIV. And sadly, 22,000 new mother-to-child transmission of HIV yearly. Some other details are right here on the front page of The Guardian. You can pick up a copy to see that. All right, away from that, we have Senate moves forward with tax reform bills as critics call for caution. Below that, shun migration. Federal government tells fresh foreign trained medical doctors. Details of that is on page 6 of The Guardian. Below that, witness tells court how he collected $400,000 from Emefiele. Global wages outgrowing inflation, says ILO. And we have Amnesty International accuses police of killing 24 protesters in Kano. Others. All of that's on page 30 of The Guardian. Emphasis on individual success wakens political action. That's according to Osinbajo, the former vice president of the Federal Republic of Nigeria. And below that, we have electricity subsidies skewed against masses. Minister affirms, and that's on page 7. All right, let's look away from The Guardian now and see what this Nigeria is offering this morning. It leads with, we will return out of school children to classroom. Tinubu tells Macron. Interesting. The Riders says no child should go to bed hungry. Says any more investment in food security, solid minerals, other sectors from France. That's what this Nigeria has on the front page. And away from all of that, we have in a beside the picture story, crashes. FRSC moves to revoke licenses, prosecute offenders. Below that, FCT list of outstanding payment of CFO bills. That's also right here. And then tax reform bills for second reading in Senate. Proposed new sharing formula. Code 55%, cede 55% to states. And just beside the masthead, finally this morning on the front page of this Nigeria, we have only 200 psychiatrists catering for over 200 million Nigerians. APN laments. Only 200 psychiatrists catering for over 200 million Nigerians. APN laments. So that's it from this Nigeria this morning. Victor.
All right, I have the Vanguard here, and the lead story reads, tax reform bills offer 55% to states in new sharing formula. And that story has several riders. Target zero VAT on exports, essential commodities. Reduce burden on small businesses. Reduce company income tax from 30% to 25%. Senate passes bills for second reading to conduct public hearing. Gives committee 6 weeks to revert. We will do what is good for Nigeria and Nigerians. That's according to Senate President Akpabio. Ndume kicks as Bamidele, Musa, Dixon, Moro, Monguno support bills. All right, and above the nameplate, manufacturing sector contributes 5.02 trillion naira to economy in 9 months. For details, get to page 19. Polytechnic lecturers begin strike December 2. Not again, you say? Well, details of that story is on page 2. And Bode George tackles Onanuga for insulting Obasanjo. That one is on page 10. Tinubu to Macron. A starved nation won't care about weather, environment. That one is on page 4. And bad governance protests. Police killed 24 protesters in 6 states. That's according to Amnesty International, and it's on page 7. And in sports, FIFA ranking, Super Eagles drop 8 places after loss to Rwanda. And since Chukwudi Okoli-Ubaja is unable to join us today, well, Yenre, let me read you this. Mr. and Mrs. Mr. says it's a pity, really. All the women keynote speakers did not show up at the workshop. And then Mrs. says, with the present harsh economy and the theme, money can't buy love, no woman will attend. Is that the case?
Of course. That hits the nail on the head. Without money, there's no love anyway.
So that's why women won't attend the workshop.
Money is needed to get to the workshop in the first place.
Okay, let me agree with you. So that does it for us on the newspaper review segment. Good morning, Nigeria.
This coverage of the German Bundesliga.
All All right, welcome back. It's still Good Morning Nigeria, live on the network service of the NTA. And just before we get into the conversation, which is on sustaining the fight against HIV and AIDS, let's quickly take a look at this background report put together by our correspondent, Oyeyemi Ajayi.
The HIV/AIDS epidemic remains a public health challenge in Nigeria, with about 1.9 million people living with the virus in 2020. Despite progress in controlling the epidemic, challenges remain, including inadequate funding and limited access to prevention and treatment services for key populations. Experts believe the contributions of government agencies, international partners, and civil society organizations have gone a long way to reduce this epidemic. There is the need to strengthen surveillance systems, increase access to testing and treatment, enhance prevention strategies, address stigma and discrimination, increase funding, and expand research and development. The impact of antiretroviral therapy in HIV management is also a major issue of concern. Over the last decade, Nigeria has made significant progress in controlling the HIV epidemic with a decline in new infections and increased treatment coverage. However, more work is needed to achieve the 95-95-95 targets set by the Joint United Nations Programme on HIV-acquired immunodeficiency syndrome for 2030, and a multi-pronged approach required to address the social and structural determinants of health that drive the epidemic.
This year, we are placing special emphasis on stopping AIDS among our children, as well as raising consciousness on sustainability and ownership of the HIV response.
With the theme for the 2024 World AIDS Day, Take the Right Path, are the people actually taking the right path in the fight against the disease? How much progress can be said that Nigeria has made so far in the fight against HIV/AIDS? Are we really winning the war? What about prevention of mother-to-child transmission of HIV/AIDS? Our guests will be answering these and more questions shortly.
All right, Oyeyemi Ajayi, many thanks for that background report. And to begin our conversation on sustaining the fight against HIV and AIDS, let me start by introducing very specially, it's your first time in our studio, Dr. Temitokpe Ilori, Director General, National Agency for the Control of AIDS, NACA. It's a pleasure to welcome you to Good Morning Nigeria.
The pleasure is mine. Good morning, Nigerians.
All right, also joining us for the conversation right here in the studio is Esther Hindi, the National Coordinator, Association of Women Living with HIV and AIDS in Nigeria. Many thanks for joining us, ma'am.
Thank you, and good morning, Nigeria.
All right, let's, since we have the DG here, it will be good to know where we are. There are so many targets, so many statistics, but where are we in the fight and control, the fight against and control of HIV and AIDS in Nigeria?
Thank you very much. I would start by saying that we are making steady and good progress in the fight against HIV and AIDS. I say that because if you look back, 10 years ago, the prevalence was as high as 3.6, 3.9 in some states. But as we speak, the prevalence of people living with HIV/AIDS in Nigeria is about 1.4% of the total population, which is still quite huge considering that we have over 200 million Nigerians, and that's estimated is about 2 million Nigerians are living with HIV/AIDS, and about 1.6 million of these people are on treatment. So indeed, the prevalence is still high. Yes, we have a global target of 95, 95, 95, and what that means is that it's estimated that at least 95% of people with HIV/AIDS, we know their status. At risk of HIV/AIDS, we know their status. And out of those 95%, 95% of them would be on treatment. And out of the 95% on treatment, at least 95% of them, we have a low viral load. That is viral suppression. And what that means is that if your viral load is very low, if you are virally suppressed, then you will not be able to transmit the infections to other people because you are as good as being negative. In fact, if you take an HIV test at that point in time, it will be seen to be negative because the viral load is so low. And that is what we are advocating for. And that is why we are encouraging people to go for testing, to know their status, and if positive, to access care, to be put on medication so that they can be virally suppressed. So as we speak now, our statistics is 85, 85, 82, as against 95, 95, 95.
All right, I want to take you up on this on your opening statement that we're making steady progress. When you say steady progress, I want to know what that means, because I can see that 22,000 new mother-to-child transmission still happens in this country yearly.
Yeah.
So if we're not able to stem the mother-to-child transmission, it means in a few years, the numbers are going to increase because more people are getting infected, or rather more children are getting infected. And then the statistics show that at the moment, Nigeria contributes to 25% of the global burden of HIV mother-to-child transmission. I mean, talk to us about this.
Yes, you are very correct, and that is why the theme for this year, taking the right path, sustaining the gains, but then we have the clause, of preventing mother-to-child transmission, because that seems to be our bane in Nigeria as of today. You're very correct that, yes, Nigeria contributes 25% of the global burden of mother-to-child transmission, and therefore we have the highest number of children born with HIV/AIDS as a country across globally. It's multi-sectorial, it has many factors because it has to do with antenatal care. Like I told you, yes, people are getting tested, but unfortunately, pregnant women are not getting tested for HIV/AIDS, and it's because they are not accessing antenatal care. Statistics shows us that about 62% of a Nigerian woman, we go for antenatal care. The remaining 23% or so we deliver at homes, or deliver in traditional birth attendants or in the mission houses. And many of these facilities do not have, the HIV testing or facilities. But what we are doing as a government now is that we've mapped out all the facilities that women could possibly access care. We've mapped out, apart from the conventional health facilities, primary health care centers, secondary health care centers, teaching hospitals, we've as well mapped out the traditional birth attendant facilities, the mission homes, and we're equipping them with test kits, HIV test kits, so that when they see this woman, they can test them for HIV. If found to be positive, we are linking them on with healthcare facilities where they can now access, HIV medication and drugs, which, by the way, is entirely free.
And what factors would you say account, apart from, of course, the maternal aspect of it that you have tried to explain, what other factors contribute? Certainly, they are not the only ones that up the numbers. So what other factors account for Nigeria being where we are at the moment?
Well, we refer to something that's social determinants of health. Apart from health itself, we realize that culture plays a role. In some places in Nigeria, women just have to deliver at home. They're forbidden or they're not encouraged to go to the hospital. Religion plays a role. People have different religious aspects. Finances plays a role. People may not be empowered to visit these health facilities. And in order to address the financial situation, as a government, we've introduced what we call the National Health Insurance, wherein there's a vulnerable group category. They come under the vulnerable group. So you can register under the National Health Insurance Scheme as a vulnerable group if you're a pregnant woman, if you're a child under 5 years old, if you're HIV positive, a person living with HIV at a very reduced token. And then you get the comprehensive care aside from the usual antiretroviral drugs, which are entirely free.
You didn't talk about access to basic primary health facility.
I'm actually
has also
there.
been an issue. But you see, I want you to talk about what we're doing as regards this HIV burden. I want to know if, as a country, considering the number of, the amount of donations and support we get from the international community in the fight against HIV and AIDS, if we have actually done the needful as a country. I want you to speak around that, because tell us, in terms of donations, how much does the country receive? Because I know that the medication, a lot of things, these are gotten free. It's not like, it's the government of Nigeria. They're gotten from international donors. And then funds are also being, set aside for this from charity organizations across the world and all of that. Has Nigeria actually, been able to use all of this effectively? Are there other issues affecting why these numbers keep rising?
Yes, we've been very judicious with the funding. I'm not saying we are 100% there. I'm not saying we don't have some itches here and there. But yes, we've been very judicious. And that is why the numbers, like I keep emphasizing, they're coming down. But not as steeply as we wanted to in order to achieve the global target. And like I said, there are many other factors, even beyond health, that is affecting, this prevalence. And I've highlighted some. In terms of the donation, there's HIV came to us as an emergency about 40 years ago, and we have donor partners, international donor partners, the US government in particular, the Global Fund, and so many others that have been assisting since then, particularly with treatment. Yes, you're very correct. All the antiretroviral drugs that we use today are imported. None is produced in Nigeria, and that is why, as a Nigerian government, we're taking steps to to start local production. I want to commend our President Bola Ahmed Tinubu, for setting up the Presidential Value Unlocking Chain Initiative, PVAC, and we are working closely with this organization, with this committee, to ensure that we start local production. I was in China a couple of months back. We actually signed some MOU with some producers of antiretroviral drugs, and we are hoping that come next year, first quarter of next year, they will start their production plant. Not only antiretroviral drugs, also test kits, rapid test kits for the HIV testing, condoms. Many of the condoms we're using now are imported, so we have that, and also, of course, the enabling environment produced by the government, because now we have tax exemption, zero tax on pharmaceutical companies, zero tax on health commodities, and this serves as an incentive for producers to come and start production here. So when we have that, it will help us to reduce the cost of these medications. As we speak to you now, it costs about $100 per annum for ARV drugs for an individual to use, and we have over 2 million of them, using it.
All right, let's pause you.
Let's keep her on hold, I guess, so that you can take a breather. We'll be back to you. Esther, well, good to see you.
Thank you.
I'm sure you would have more first-hand information on what the factors are that are making it difficult for people who have HIV or AIDS to know their status, and for those who even know their status to be able to access the care that is needed. What is your experience?
Well, thank you very much. Let me start with where my DG stops. Talking about some of our socio-cultural norms and values, where we know over the years the issue of stigma and discrimination has been an issue related to HIV and AIDS. And because of that, a lot of people find it difficult to come out and even test to know their HIV status. Okay. So coming out to test, because anytime you go and people want to, people learn to be quiet or discreet about HIV testing. Unlike when you go to hospital, it has to be like you go for HIV test, that fear will always come. Coming to people who are living positive also, the enabling environment, access to commodity and services where discrimination is still on the rampage. HIV is still tagged as a promiscuous way of infecting individual or getting the HIV. Our cultural acceptance, and then the fact that you don't talk about HIV, or I don't come out open free and say I'm HIV positive like any other disease, and people would not have a second look at you. So issues like that are still factors, that hinder people from accessing their services, ARVs, and then also going for the test. And then even sometimes in the family setting, you see somebody that is living positive that cannot even freely talk to his family member because of the issue of stigma and discrimination. You'll be stigmatized, you'll be looking, you'll be like, how did you get that infection? Which we know there are several modes of transmission of getting the infection through screen blood that is infected, through using of sharp object and other things, and then the mother-to-child transmission, whereas in the coming back from 40 years where we started to now, a child that is born with HIV is now 40, an adult, a grown-up adult that possibly is reaching his peak of middle age. So, and then what will you say about that person? He's born with it, he finds himself in it, and he has been on his medication. And to be truthful about it, he's doing very well. There's nothing wrong about him. You see him, he's healthy and he's living well. So some of our, norms, beliefs, and then still that notion, that misconception about HIV still scare people away from the, HIV issues.
Esther,
Yes.
I want you to, many years back,
yeah,
HIV was on the lips of almost everyone.
Yes.
The sensitization was high, jingles were everywhere, posters, you go to the hospital, for everything that you want to do, you're tested for HIV.
Yeah.
Did something go wrong at any point? Because, you would expect that, looking at how many years down the line, by now we shouldn't be talking about some of these issues.
Yes.
Stigma and all of that should have gone because, everybody knows about it, and then you know that, did something happen to the agencies that are supposed to manage all that it takes about this disease? I'm just asking because, there was a time that NACA was a very popular agency. I don't know. I don't know about now. No. I don't think a lot of people watching you would agree.
Yeah.
Do you think that there was a point where agencies and the government, relaxed in dealing with this?
Yeah, definitely I would say yes, because if you look at from where it started, just as you have said, that over the years there are a lot of awareness creation, you can hear it everywhere. Like 3, 4, 5 years ago, even the celebration of World AIDS Day, it has been like in a low-key, whereby when you go to the state capitals, you see all our SACAs are no more, proactive, active when it comes to, because of the dwindling of funding, and then, some level of government commitment over the years. But thank God for the new government now. We have started seeing a lot of changes with our new DG, who is a female and very proactive and doing very well. Like from last year that she came on board, that at least this year, I believe you can feel the tempo of World AIDS Day celebration almost all over the 36 states and FCT. So awareness has really gone down because of recent, I've gone to communities and engaged with stakeholders. Still, does HIV still exist while we still have new infection? So in terms of awareness, definitely awareness. And then we have the anti-stigma law, which has been passed, 2015, which has been passed since and it's been in existence. But where is the implementation? You still go to states, communities, and people are being discriminated and, stigmatized, and there's nothing being done about it. So, and then if you have a law like that, and then the law is somewhere kept, and then some states have not even domesticated it, so, it's still an issue. So I would say yes, along the line, something happened. There's, a lot of people divert from maybe creating the awareness, and we go back to prevention. And then we even forget about the care and support of the people living with HIV and AIDS, whereby you still go to the facilities, you go to a labor room whereby you're expected that every woman that comes to deliver is tested, and you go there, you can't find a test kit. And then that woman that is positive that comes, she's being blamed that why didn't you say you are HIV positive and you came to the labor? It's not her own to say it. She's already in pain. She have come to deliver. All she needs is to obtain that services. And then you even go to the antenatal care. Hundreds of women will come for an antenatal day, and there's no test kit to test them. So with all this shortage and stockouts at a point in time, it really affects, and it gives opportunity for more, new infections, especially for our children, because transmission of mother to child transmission is something that can be prevented even before it happens. And then when you don't have the necessary commodities and available of services that the woman can obtain, then, transmission can happen, which we don't know where, whether when the baby is in the womb or at the delivery course, that's at the labor ward or anywhere. So I think there's a gap. And then talking about the gap when it comes to attending the 1995, 95, we really need to, put more, because those times that we have left those gaps and created that opportunity for more infection. And then now it's time for us to bridge it, because our children that are already positive, that are on treatment, we need to bring. We have now. I think the recent report shows that it's only 40% that are on treatment, and therefore PMTCT, which
just
is
35%,
40%.
Okay.
Yeah, for children on treatment. So with that, I think.
But the global set standard is supposed to be 95%.
Yes.
And then, okay. Anyways, I think that we'll get back to you to tell us some
just
more.
so that I understand that Kanu is ready for us. So let's quickly introduce from Kanu's studio Usman Bashir, who is DG Kanu State Agency for the Control of AIDS. A pleasure to welcome you to Good Morning Nigeria.
Thank you for having me. Good morning, Nigerians.
Right. Let me stay with you. Kano State has relatively low prevalence when it comes to HIV and AIDS, at least compared to many other states. But the DG of NACA has mentioned a number of issues why the prevalence is where it is in Nigeria. Culture, religion, poverty, stigma, largely. All of these depend on awareness. If the people are aware, culture wouldn't be a problem. If the people are aware, religion wouldn't be a problem. Even poverty. If the well-to-do amongst us are aware, you know, how much they can do, it also wouldn't be a problem. And then you talk about the stigma. It all boils down to awareness. Would you say that we are doing enough in this regard?
Thank you very much for having me. I think as Nigerians, we've started doing something, but I can say we have a long way to go in reducing stigma, barriers to access to healthcare. And like my DG said, I think it's very important to improve for us to get getting children not getting infected from HIV. We need to start from making sure that the women attend the ANC. And like in Kano here, we already started what we call engaging the men, role of men. We're trying to make the men understand the need for their wives to go to the hospitals so that they'll be checked and do the other thing. And then another thing too that we have done as a government in Kano, the premarital screening law has been passed, which means that for you to get married, you must be tested for HIV, hepatitis, and sickle cell disease, because that's the entry point. And then testing you, it doesn't mean that you might not get married, because there's what we call PrEP. There are other methods you can use whereby even if the person, what we call the discordant couples, if one of the couple is infected, can still go ahead and get married. And we've already put that in process. And also the anti-stigma law. And we also have what we call mentor mothers, who are members of the NEF1 who go into the community to reach the unreached, whereby, you know, in some communities, either due to lack of access to services, or the services are not reached, or the people, like you said, the poverty, people cannot afford to go to those people. So these mentor mothers, who are also part of the community, who are taken from the community, go around and see that they link up these pregnant women to the service providers so that they will be tested for HIV and tested. Another thing is the commodity supply, because in some places you don't have commodity supply, but alhamdulillah in Kano State we have been getting our consumables like the test kit, which we're using now, even the combo. We're using the one that has HIV and syphilis and the hepatitis B, so that at least all pregnant women will be screened for these 3 diseases. And also collaboration with TB, HIV. We're also, like we have here in Kano, HIV is under our roof, meaning that all HIV, the health sector and non-health sector, because as we know, HIV is not only a health-related disease. You need to look at other social factors that in the society, like the education. You need to improve the education, like you said, the awareness. And also, you know, even the prevalence in Kano, even though you said the prevalence is low, Kano is the most populous state in Nigeria. So if you look at the prevalence of 0.6% and put the numbers, 20 million inhabitants, and take another state that has a prevalence of 4 or 3%, and maybe they are only 2 million, you will see the absolute number is more in Kano than in those numbers. And then also, we have a lot of immigration, people coming into Kano because of the safety and the commercial that are happening. So people are coming from non-secure zone, places that have insecurity issues, so they are coming in with their culture and values, which might be different from the one here. So, and then also poverty, like you said. There's a lot of activities that are carried out that will affect the control that we're having in the states.
Many thanks, Dr. Usman Bashir. I'd like you to, speak around, specifics, what you're doing in Kano State, in dealing with those who already have, who have already been tested positive for HIV. I want to know, tell us, as regards access to medication, access to medical facilities and personnel. I know. Tell us the state in Kano. I just want to know if they are being properly managed at the moment. If those in rural areas have access to their drugs. What the Kano State agency is doing to ensure that the viral load for those who already have it is as low as possible.
Yes, thank you for asking this. Currently in Kano State, we have 592 health facilities that are testing across the state, which are spread across the 44 LGS in the state. And we have 43 comprehensive sites, meaning that these are facilities that provide HIV care and support, whereby they have access to their drugs and other services. We have support groups. We have functional NEF1, APIN, and ASHWAN, which are also housed in the agency, meaning that even the NEF1 headquarters is in Saka. And not only that, also we are testing in those facilities, both for the general population and for the pregnant women in those comprehensive sites. And like I said, if a positive woman or any other person is found, there's what we call hubs and spots. We have identified the comprehensive site and linked them up with the primary health care facilities or low-level facilities that will link them up to care. And not only that, in Kano, we are also providing the third-line medication. That is the third-line drugs. We have the fourth-line ARVs, second-line ARVs, and the third-line ARV. Recently, there was shortage of the third-line medications across the country, but my governor graciously approved for us to procure those third-line medication, and currently we have 21 clients on those medications. And currently we have 32,682 patients currently on care across the state who are receiving their drugs for free and assistance service. And also, we've looked at the vulnerable group. In Kano State, we have what we call Kashma, that is the health insurance scheme. Currently, they have, using the equity fund, we have identified 2,500 vulnerable PLHIVs that have been put into care, that are receiving care, comprehensive care, meaning that not only for the HIV, for any other disease they have, they will access care for free. And very soon we will also enlist another 2,500. So this will go on so that at least even if the partners go, the government is already taking over that. That means our sustainability rope is in place, and we're already building the capacity of the healthcare workers, the SACA staff, so that when the partner and when we are linking up, we are like the whole SD we are doing now in Kano. We'll start tomorrow. We'll start with the youth group. They're going to use social media to discuss HIV preventive practices along their peers. And then the next day, we're going to have the Senate meeting of NEF1. On Sunday, we're going to have church services, and then the NEF1 group is going to have a Senate meeting. Then on Monday morning, we're going to have a health walk in Major Street in Kano. That is the Abuja, where we'll move with all the head of other agencies, NEF1, CBOs, CSO, TB, HIV groups, all other relevant stakeholders with the Commissioner of Health of Kano State and all agencies of health. From there, by 10 a.m., the Commissioner of Health, in Kano, Saka is under the Ministry of Health. So he's going to have a press briefing where he will inform the world what Kano is doing in terms of response, what we have done this year, and what we plan to do next year. Then also we're going to have a debate by children affected by HIV. They're going to have a quiz competition where they will feel included. They will be given, there will be prizes they will be given. And then we're going to have...
So Usman Bashir, there'll be time, for you to tell us all the programs that you have mapped out for this year's celebration. I will get back to you, but let's quickly get back here in the studio. We have joining us now for the conversation Dr. Daniel Joseph, the Program Manager, Technical Adult and Pediatrics HIV Institute of Human Virology, Nigeria. Many thanks for joining us, Dr. Joseph.
Yes, thank you.
All right, I'll get to you, but let's get to the DG now. She wants to respond to some of the comments that have been made so far. But while you respond, I'd like you to tell us what the challenges really are, not on the part of the people, because you talked about culture, religion, which is, basically, the people, but on the part of your agency and other agencies saddled with the responsibility of dealing with this. The reason I'm asking that is because the statistics show that at the moment, there are 15,000 deaths recorded among children yearly. 300 happen weekly in this country. I mean, the figures are...
Yes, thank you very much. The figures are very alarming, and that is why we are having all this awareness and advocacy visits. Let me start by commending the Kano State government for all that they're doing in terms of HIV prevention and AIDS and all the resources they've mobilized. And I just want to use this junction to also appeal to other state governors to do likewise. Even though, like we said, we're mobilizing funds at the federal level, but we know that government is in 3 tiers. We have the federal government, we have the state government, and we have the local government. And I'm happy with the local government autonomy now. I'm also trying to appeal to the local government chairman to also do likewise, because we actually have local government agency for the control of AIDS in every 774 local government area, but they've been quite moribund because of lack of funds. So this is a strong advocacy to government, even though we're working with the government forum in order to raise their awareness and sensitize them on the need to actually mobilize resources, for the care and prevention and care of HIV/AIDS. And okay, what is the issue on the part of government? As I speak to you, most of the funds used for the national response of HIV is actually donor funded. Majority, about almost 90%, regrettably, is from international donors, like I mentioned earlier. But as with the new renewed initiative of the president and with the X-Sector Renewal Initiative, we've been seeing an improvement in the budgetary allocation to health, and particularly to the HIV response. And we believe that this is going to keep improving. And like we said, we are also lashing on the National Health Insurance Scheme. Just in the last 1 year, over 2 million Nigerians, vulnerable Nigerians were registered on that health insurance scheme. There is a pilot now in about 5 states. I know Gombe and a few other, Lagos and a few other states, 5 states going on to actually pilot this. And of course, they derive their funds straight from the basic healthcare provision fund, which is about 1% of the consolidated revenue of Nigeria. So
are the antiretroviral drugs covered?
No, they're not, because as we speak, like I said, as we speak, the drugs, antiretroviral drugs, are free for every PLHIV.
With or without insurance?
Yes, they are free. The insurance is to address other
concerns.
Yes,
medical,
because obviously the fact that I'm HIV positive does not mean I'm not diabetic. I could be hypertensive. I could break my leg. I could have a fracture. So it's to address other concerns. But as we speak, as of today, all antiretroviral drugs, all testing concerning HIV are free.
But tell us, why did the testing and the media, is it just the media, not media, the awareness, by the agencies, SACA, the states, and other, why did it sort of diminish? Because, I mean, there was a point that you get to every junction, there's a testing happening. Yeah. You get to every conference, there's a corner where they're telling you get tested. Yeah. Something...
Yes, well, leadership, governance and leadership is a key role, and that is why we are here now, to rejuvenate and to reinvigorate the tempo. Of course, funding was a major issue too. If government, like we said, most of them are donor funded. So
but it has always been donor funded, even from the very start.
Yes, but there is donor fatigue now. And even from the donors, the funds are dwindling now. They are reducing. They are still here with us, but they are reducing. Tomorrow they could decide not to fund us again if they so wish, So now that is why, as a government now,
what do you think is responsible for the dwindling donor
because there's
support?
International recession. Globally, there's a recession. So of course, they will prioritize their own citizens first than the aids they're giving to other continents.
Not misappropriation on our part or anything they
I wouldn't say there hasn't been cases of misappropriation in the past. but that is not the only reason. But as a government now, we are taking ownership. We have what we refer to as the sustainability agenda. We have a sustainability framework. We're talking with our donor partners. We're talking with our implementing partners and other sister agencies. And we already have a blueprint to say, where do we go from here? What if the donors leave us today? What do we do? So we're beginning to empower our own government mandated structures. We're beginning to have a structure to say resource mobilization, both budgetary and even in the private sector. We have what we refer to as the HIV Trust Fund, where we are talking with the private sector, to help to fund that, and that could be also put in use. And we also, as a government, also to address some of the challenges. Yes, pediatric age group HIV is a huge burden in Nigeria. The same thing for prevention of mother-to-child transmission, and that was why the Honorable Minister for State for Health inaugurated what we refer to as an acceleration committee, to kind of implement the Global Alliance, plan, and that is to make sure that no child is born HIV positive. And this is that was done nationally, and we've domesticated that in the state. For instance, I've been to Ekiti State, I've been to Borno State, I've been to Ogun State to inaugurate similar committee at the state level. And we'll do this across the 6 states of the Federation. And their aim is to make sure that, they monitor the progress. Like we said, it's multi-sectorial. It's not just the drugs are there now, but are the women accessing the drugs? Are they coming to the hospitals? Are the health workers trained? So far, we've trained over 20,000 health workers. We plan to train about 140,000 before the end of the year. These are going simultaneously going on across all the 6 states of the Federation. Of course, we are working in collaboration with the National Primary Healthcare Development Agency, a sister agency, in this training. We are doing multitasking. We are doing task shifting. We're training volunteers to fill in the gap. Of course, the Japa syndrome has also significantly affected our healthcare providers, the population. So we're just thinking out of the box to fill the gap.
All right. Dr. Elori, many thanks for your contribution so far. Let me get on to Dr. Daniel. Now, it doesn't seem like Nigeria is making the kind of progress, not that there's no progress being made, but the kind of progress that will get you across the line, in 2030, for instance. So why does it seem that HIV and AIDS, apart from funding, which you talked about, well, I have also thought of awareness. Why does it seem that we are not making the desired progress at the moment?
All right, thank you very much. I wouldn't want to say we hadn't had enough progress in that direction, but I would say the progress has been slow anyways. But again,
I'm saying the same thing.
again, we will get there because there has been a surge in activities in the HIV space. Reason being that, like the DG had rightly said, funds have been dwindling. And then now Nigeria is heading towards a sustainability plan. So therefore, efforts are being sought to see how we get to end AIDS by 2030. Now, some of the plans that we have made in that direction is to see how we ensure that we get to quite the underserved populations, which include pregnant women. We have seen that prior to this time, we had been focusing on facilities, case finding in facilities, and forgetting the pregnant women in communities that are underserved by our activities. Therefore, right now we are making efforts to see how we reach out to all communities to find pregnant women. We have seen that over 40% of pregnant women are in the communities, and it is only when we get to them in their areas of abode that we are able to harvest them, cut the chain of transmission from mother to child. In that respect, we will be able to cut down on pediatric HIV, which poses a problem to us. Then again, we are seeing that other people, there are some imbalance in the population we serve, like for key population, men who have sex with men, female sexual workers, and some other prototypes of the key population. They are unreached. This can be attributed to the fact that our society does not really give them an opportunity to reach out for HIV services. some of them are just hiding in their bunks, and because our socio-cultural it does not allow them to reach out to these services. So we are trying to reach out to this key population and invest them in the community. So again, law enforcement agencies have a key role to play, because most of them are being harassed, as well as some of them don't get the opportunities to reach out for HIV services because of their identity. All right. So part of our plans is to see how we cut the chain of transmission coming from this key population who are the reservoir of the transmission. So again, we are trying to see how we upscale HIV self-test distribution across to communities and our populations. So what we are doing now is to, across the 36+1 states, we are upscaling HIV self-test distribution to communities and hard-to-reach areas. We believe that those who are unable to go to facilities to get HIV services and get tested, who at the comfort of their houses be able to do HIV self-test for them, and then they are able to identify with us. These are some of the efforts we have put in place to see how by 2030 at least we'll be able to get there, and we are very optimistic.
But all of the things you have mentioned can still be tied to a lack of awareness, or at least inadequate awareness. So how can Nigeria strengthen its HIV and AIDS awareness and education efforts, particularly in schools and, like you have mentioned, in communities?
All right, thank you very much. Again, it goes back to government commitment, right? There are communities that are naturally inaccessible to some of our activities, but it's only government who have some kind of media outlets in, say, there was a discussion formally where we had a stakeholder discussion based on creating awareness in communities that are underserved by our program. But we came to realize that government have a way of reaching out to these communities that are hidden from eyes. So government's commitment using their media outlet like NTA and some grassroots media can help us reach out to these communities and serve them in the languages they understand. Because most of our programs, we tend to use English, we tend to reach out, use people outside the communities that are being served to get services to them. So if government can make it statutory for us to be able to serve these communities using media outlets in these communities, and then community engagement too, using various stakeholders at that community level, then we'll be able to get these services across to them. Like I'll give a striking example. In the north, the women are hidden from the public eyes. We can't go to their houses and harvest them. It only takes commitment in the part of government to be able to interface with stakeholders and some of their cultural leaders in those areas for them to be able to bring out the women to be tested.
All right.
And if we are unable to reach out to them, definitely there's nothing we can do as an organization without government's commitment.
Thank you. Dr. Daniel Joseph, government's commitment key. And, you know, when we even talk about the statistics that we have, you want to ask if the statistics are correct, because a lot of people have not been tested. And then this mother-to-child transmission being a major issue. And I'm just wondering that a lot of children roaming the streets now with HIV, no access. They don't even know, not talk of having access to treatment or the medication. That's a big problem. But let me talk about what your institute is doing. Institute of Human Virology, that's where you're from. Tell us, is the strain of HIV that we have with us now still what we used to have? Is there some form of mutation? Is it still... Just let us know how the virus is behaving at the moment.
Well, okay, thank you. There's a lot of research ongoing. Okay, as we know, there are majorly two strains of the HIV 1 and 2. All right, and over time, the epidemiology has changed over time, but has remained fairly constant for us in Nigeria. All right, the drugs we are using are very highly active, okay, like the emergence of dolutegravir as an ingredient of the ART we use has been very effective. So clients who are enrolled in care, given 6 months, tend to be virally suppressed. That is to say, definitely the drugs we are using have been effective. So we wouldn't say if there has been a change of strain, definitely there will be mutations at molecular level that will definitely impact the effectiveness of the medication. But from what we are seeing, given 6 months, patients get virally suppressed. So even without doing those kind of molecular genomics and all that, we know for sure that yes, what we are dealing with, the drugs we are using are the right drugs, okay? So over time, there's been a fairly constant in our program. So we would say we have been doing well
in managing it.
Yeah.
Okay, good. Good that the virus is constant. But Esther, let's get to you. You know, I'm particularly worried about this pediatric situation. You know, it's not looking good. The figures. You know, number of children infected on a daily basis. If you don't stop that, of course, the population of those with HIV cannot reduce. I mean, it's pure. It's simple. But talk to us when you talk about. The DG has said that access to medication is free. Rather, the drugs are free. Yes, but of course, access we know is a big issue. But tell us about, are children, are parents really having, making sure their children take this medication? Because if if they don't, it means that in the short time they will die, because the number says 15,000 are dying. So is it that parents or caregivers or guardians of these children are not allowing them access these drugs? Is there any problem, as regards to children? I just want to know if there are issues in that.
Okay, thank you very much. And then the time children have been infected is transmission, because when we say infected, it's being transmitted from the mother to child, so we don't say children are being infected. So that's the language. Talking about children, naturally children sometimes don't like drugs. So it needs a lot of care, attention, and then access. So talking about access, and then I would say facilities for children to go and access their medication. So just like we say, the coverage, that the number of children that are on treatment is when the parents or the mother takes the child, deliver at the facility, and that child is being. So if the mother's care is not secondary, it's priority. When the mother knows that I access my treatment and then I'm doing very well, and my child also needs, because no mother will want her child to die or to have HIV because of her own status. But the environment sometimes, and then our women accessing the PMTCT services also, because you see the number of women that are on treatment for PMTCT is still very, very low, which we still have a lot of gap. So if you compare to the number of women that are PMTCT that are enrolled, and then looking at the number of children that are also enrolled in treatment, already the gap is there. So you should expect that death rate for children, because that means there are children that are not yet on treatment. They are not accessing treatment. Then for those that are also accessing treatment, the services is one issue, because sometimes access to these services is another challenge. For people or women that are at the grassroots or in the rural area where they have to travel to the secondary facility to access their children's medication, is an issue. So sometimes it's a matter of constraint or difficulty for them to do that. And then if the children are not doing very well, children, usually their cases are mostly difficult, or let's say delicate. So, and then if you look at the economic aspect of a woman, as in independently, we are in a patriotic society whereby women are mostly left behind, even in decision making. So there are so many factors that even the woman herself to go and access the treatment is a challenge. One, sometimes she needs to have permission from her husband or family to go to the facility. Two, she doesn't have the economic resources for her to take responsibility or decision to, I must stand to ensure that my child have, while even me myself, I cannot even have that resources to do it for myself. So there are a lot of factors. It differs from one person to another, and then from one situation or the other. So there are so many factors that and then if you look at our facilities where we access, you know, some unfriendly even facilities and unequipped facilities, because now the ARVs mostly are not in the PHCs where in the community. You have to travel to the secondary facility to go and register, you know, enroll and then access your treatment. So you have to travel there to go and access it, or take your child there to go. And so these are some factors and challenges that sometimes the community or people living with HIV or women living with HIV find themselves in, whereby the access to all these services. So the access needs to be available at every point. And then it has to be close to your community, whereby you don't need to travel, especially with the present economic situation we're in Nigeria. To fit is even a problem, talk less of you to travel to go and access, whereby the cost of transportation that before maybe you travel for 200 naira, now it's about 1,000 or 1,500 to go and come back. And then talking about you have to go maybe with your child to go and access these drugs in the secondary facility. So there are a lot of factors that really
are these drugs children friendly? Because, you know, for malaria, you know, that for a child is different from for an adult.
Of course.
So there are drugs for children
for
this?
Yes, for the children are different from the one of adults. Yeah, okay. But you know, sometimes naturally, at least over the years, we have advocate, we have, there's a lot of, you know, awareness and then advocate and testing of the drugs. Are they friendly? Does the children accept it? So there has been a lot of changes and improvement in the quality where, like, for the infants, the nevirapine that you give children at birth, they are syrup. So a child can read it, and the test is actually good. And then for the normal pediatric children also, it's really friendly. But sometimes the accessibility for them.
Of course, you have highlighted the issues.
Yes, and then, you know, sometimes community, just like you have said, the issue of awareness. You know, community engagement is really key. Because there has been this issue, this gap between community engagement and the government and the partners. You know, just like when you bring a commodity or intervention, you just batch into the community without really, you know, hearing from the community, what do they really want? How do they want this to be? So, you know, when the intervention comes, you know, you go to the facility and you find that the ARV clinic is separated from all the other clinics. So when you are going toward the ARV clinic or pharmacy, people know that, of course, you are going to receive HIV, you are already HIV positive. So that stigma alone and all these things, you know, affect people, and they tend to shy away from, you know, going there.
All right. All right. Thank you very much, Esther Hindi. I'm sure the DG would like to respond to some of these issues, but in addition, some say technology is king. And I'm wondering how Nigeria can leverage technological innovations and data-driven approaches, you know, to enhance its HIV and AIDS response.
Thank you very much. Maybe I should just start with the technology. We're using a lot of technology now. Let me just start with the basic things. We're in the social media, for instance. We have we have TikTok accounts. We have WhatsApp. Our website is very functional and interactive. We have a lot of technology. You know, we even have so many apps. You know, wherein youth, adolescents, and youths can actually, you know, interact, ask questions about HIV/AIDS, get feedback. You know, and all that. You know, we're doing this as a government. We're doing it with partners like UNICEF and so many other partners. There's the Nigeria and so many other platforms where youth, particularly the girl child, can actually access this. For instance, the commemoration with the World HIV Day, I would have a live discourse on X, formerly Twitter, you know, reaching out to the adolescent and youth on December 1st, 6 p.m., and this has already been circulated. And of course, we have our toll-free line 6222, where people can call in, you know, and it works. They will get, you know, feedback if they have questions and queries about HIV and part of that. Also talking about technology, we have the pre-exposure prophylaxis. We have the post-exposure prophylaxis. These are medications, you know, highly retroviral drugs that one could use if you, for instance, were exposed to unprotected sex and you feel, oh, you maybe are at risk of HIV, you can actually go to many of this, some of these facilities and access, pre-exposure prophylaxis and even post, exposure prophylaxis. This is also trying to leverage on technology. And then we also have what we call the one-stop shops. Though these are a bit coded because they are for the key population. As Doctor has alluded to, we have key population, commercial sex workers, men having sex with women, transgender, lesbians. I know the government, there are laws banning this group, but we must not shy away from that. They do exist with us. In fact, they form about 3% of the general population in Nigeria, and unfortunately, they contribute as high as 25% of the new infections. Because just like you said, they are not accessing care because there's a law discriminating against them. There's no, so they don't come out, But we as an agency, of government, we have a way of reaching out to them because we have to keep everybody safe and we have to keep them safe so that they don't transmit the infection to other people. So we have what we call the one-stop shop. They are not in the conventional health facilities, but we know they know how to get there. We have accesses for them, drugs, medication, testing, condoms and all that. We have people living with people using drugs, illicit drug substances. They contribute as high as 11% of the new infections. As an agency, we have what we refer to as the harm reduction initiative, where we counsel them. In fact, we have an incentive that when they come back with their used needle and syringes, we give them fresh, clean needle and syringes. This is to avoid them sharing sharp objects because that is the major route of transmission. So we're doing this, in order to keep everybody safe. Regarding the community engagement, of course, like we are working, like I keep saying, HIV is a multi-sectorial response. So we work with, so many stakeholders. We work with faith-based organizations. We work with traditional leaders. We work with, so many implementing partners that actually work in the community. Sometimes we do market outreaches, working with the market women and market leaders. We go to churches, we go to mosques, to do testing and counseling and all that. That is to also keep everybody safe. And also leverage on the children too, because we appreciate this burden. Like I said, we have this acceleration plan, and we are also, now we're going back to the data. We are looking at the data in every state plus one of FCT and say, okay, where are the pregnant, where are the mothers that are positive for HIV? And then we look at them, how many children do they have? And then we look at them, are the children, are they negative, are they positive, are they listed? So like a family genealogy, and that is what we refer to as line listing. And we're taking note of that. And when that is phase one. And when we finish that, as many of the children that have not been tested, we are going to go to their homes and we're going to make sure that they are tested.
Across the country?
Yes, because we have partners working across the country. It's not just NACA doing it. We are working with different partners in all the 36 plus 1 states.
When you say across the country, is it just the state capital or you intend to go to the rural areas?
Yes, every facility that is offering HIV services, we would be there. We would be there.
All right, let's take a break now. The conversation will continue in a bit. Stay with us.
The business environment, to be honest with you, has been extremely hard on most Nigerian women's businesses. And of course, harsh for a number of reasons. There is no way you would increase or move a subsidy and increase the price of fuel that it doesn't have the counter effect. It has been very challenging for so many women. I know that a lot of them have cried in one way or the other to us to find ways of intervening. But that is not to say that it is all doom and gloom. We will still have a few percentage of women that are thriving in this economy, but we hope that we'll be able to get a larger percentage. One of the things I've seen with even our local purchases now is that people are buying more made in Nigerian options of food, of clothing, and so on and so forth than the imported. So that again is helping some of our industries thrive. Surprisingly, the telecommunications is still doing well, and the reason is very simple. A lot of people are going for online options of skills in terms of training, communications, even remote working. And so you will see that people that provide services around those areas also thrive. But I think at the end of the day, it's about partnerships, collaboration, and influencing power from especially the private sector and even the public sector. But we really need the public sector to drive a number of things, especially policies, because the public sector has the national spread above even whatever we can do in our own small way. What has happened over the years is that even the government, for example, is being pulled from different angles by all these stakeholders. We need to harness ourselves to have strategic focus areas, and we should all be moving in the same direction, not using a competitive approach, but a collaborative approach. Secondly, in collaboration, we need to move with large clusters of decision makers. Instead of, the process of reaching out to individuals is painstakingly long and it takes time. And so we need to engage these stakeholders on a larger platform. I think it's very important to identify where you can get help in your own little way. And one of the things I've realized is that when you operate in silo, it is difficult for you to lift yourself out of the situation. Identify ways you can do what you are doing in a simpler way. And if what you are doing is no more profitable, why not find out what can you do in the meantime that will help you? You need to think outside the box and then connect. What you can do is also identify people and become a cluster to provide a service that ordinarily you cannot do alone.
My champs, they use energy at school.
Your champs need nourishing energy. Give them the new and improved Milo at breakfast.
It has nutrients that support energy release.
Milo! This Sunday, live on Sporty TV. Real Sociedad versus Real Betis. Watch live on Sporty TV. Brought to you by SportyBet. Play with champions.
Hey Nigeria, ready to breathe cleaner air and save money? Let's talk about gas. Drive with CNG, the smart, cost-effective choice. Fill up for less and travel further. Save money, save the planet. Switch to LPG for cooking. It's cleaner, healthier, and better for environment. Say goodbye to smoke and eye problems. Do you know Nigeria is a gas nation ranked 9th globally with over 209 trillion cubic feet of gas reserve? Gas isn't just for cooking and driving. It powers industries too. Cleaner, cheaper, and more efficient. And the best part, conversion centers are popping up everywhere. It's never been easier to switch to gas. Join the cleaner energy revolution. Choose LPG for cooking and CNG for your vehicles. Clean energy for brighter future. This message is brought to you by the Office of the Honorable Minister of State for Petroleum Resources, Gas, supported by the Nigeria Midstream and Downstream Petroleum Regulatory Authority, NMDPRA.
This Sunday, Torino. Napoli. Torino versus Napoli. Live on Sporty TV. SportyBet sponsors coverage of the Italian Serie A.
All right, thank you so much for staying with us. We are still discussing the HIV and AIDS issue here on Good Morning Nigeria. Now let's head back to Kano, where Dr. Usman Bashir is. Dr. Bashir, I know that Kano isn't doing terribly, compared to many other states. But then, if there is a single state that still has HIV and AIDS, then the rest of the states aren't quite safe. So what will it take for Nigeria to achieve the UN AIDS 95 targets and end the HIV and AIDS epidemic by 2030?
And so thank you very much for asking this question. And I think it is, I think we need to have, the first thing is we need to have the political will. Like in my state, like I said, my governor has the political will. And as I can tell you this, last year the budget was around 300 million, but this year 2 billion naira was budgeted for HIV services. And we have been accessing the funds and we have been collaborating. And like I told you, even the third line drugs last year, it wasn't in the budget, but the governor graciously approved because he understands the need to take care of the health care of the people. So I think the first thing is the commitment of the government. And then also, we need to build the capacity of the SACAs. As you can see, the partners that are here, they have the capacity to implement the program, but mostly they are not, either the states are not engaging them or they are not engaging the state. So really there is a gap. So there's need for the SACAs in the state also to interact with the partners to see what they are doing and take ownership of the process so that when the partners exit, the SACAs can function effectively. And like you said, everything is not at the national. I think we can only win this fight if all states follow the path of Kanu by taking ownership of the process, putting all resources, mobilizing people, creating awareness, and making sure that people comply, and then even providing the commodities. Like the first 95, you will see in so many places the test kits are not available. So if the test kit is not available, tests cannot be done. And also we need to train the healthcare workers. We need to improve we need to revitalize our PHCs. We need to improve so that people can access, like this ANC, where the PMTC we're talking about, the prevention of mother-to-child transmission. The only way we can make high impact is for women to be attending ANC. And if the services are not available, or the commodity is not available, or the healthcare is not trained to provide service, because HIV is not like every other service. There are a lot of trainings that you need to give the healthcare worker so that he will be competent enough to provide appropriate services for the teeming population. And also, we need to engage the community. Like I told you, even now in Kano, we're engaging the CHIPS program. We know there's a program called CHIPS that is going on under the National Primary Care Development Agency. So we're engaging them so that they will also liaise with these mentor models. We have almost 450 mentor models that are going across different wards in the state that are going around looking for those pregnant women. That is the first 95. The second 95 is, like you said, is getting those that are positive to be on treatment. And like my DG said, the drugs are available and they are free. So, and there's what we call test and treat now. You know, in the past, when you test somebody for HIV, you have to do viral load, you have to do other things before you even commence drugs. So, but now when you do the baseline investigation, you commence the drug. The last 95, that is the viral suppression, which is something that we need to do more across the whole country. Because, it's only when we suppress the virus that we will achieve the aim of zero new infection by 2030. And the only way we can do that is if patients are complying, they are adherent to their drugs, and we are checking their viral load. So we need to improve the service delivery at our facilities. We need to do proficiency testing for our labs, service providers. We need to provide the equipment. We need to provide the consumables for this test to happen. And then we must make sure that clients are compliant. And also, like I said, we need to have this. We need to at the national level and the state level. We need to collaborate with our health insurance scheme so that our client, like my DG said, they need to be incorporated so that that will take care of if the funder now decide not to provide the test kits, the ARVs, they will be shock absorbed. Already in Kano State, like I said, we are already liaising with the health insurance scheme so that even ARVs will be part of their scheme, so that even before the partners exist, already they are in the scheme. And also, we need to improve the collaboration with PLHIVs, like I said, reduce the stigma. And other states should also, those states that have not instituted their premarital screening law, we need to do that so that this will reduce, even so that parents of married couples will know their status right from the onset, from ground zero. So that the moment the wife is positive, the moment she gets pregnant, she will quickly link up with her service providers, start the medication, and we have a lot of clients that are giving birth, like I said.
Thank you so much, Dr. Usman Bashir. Kano State Agency for the Control of AIDS, thank you for your comments and the intervention that you're making in Kano State. But let's get back here. We have stated that the ARVs are free, the drugs are free, but there are reports in some quarters that in some places it is not absolutely free, and that some tests that need to be done by these people who are living with HIV are not free, and that could also be a reason why some people would not want to access, the health facilities even when they can, because they cannot afford those other tests that they need to do, maybe viral load or whatever it is, and all that. So tell us, what are you doing, to monitor and ensure that what is free is actually free, and that the things they have to pay for is as cheap as possible?
Thank you very much. I must reiterate that the drugs are absolutely free. I would also say that all the tests that has to do with HIV, viral load suppression, viral load testing, it's indeed free. The PCR, the testing is indeed free as we speak as of today. Of course, like I said earlier, I could be HIV positive and have other ailments. I may need to do my blood sugar test. I may need to do my blood pressure check. I may need to do my fasting lipid or liver function test. Those may not be free because they are not entirely under the HIV, mandate. And that is why we're saying health insurance is key, and we're advocating for every PLHIV to dash on onto the vulnerable group health insurance at the different states. This is not just going to be done at the national. The FCT and every other state would have, we have state health insurance schemes, we have the national health insurance scheme. So people should avail themselves of that opportunity so that they can have, even if it's not entirely free, a very subsidized,
No, but what are you doing in terms of monitoring? The reason I'm asking is because, you're saying it is free. Of course, it is said it is free. But, in some places, people are still being charged for these free services. What are you doing in terms of monitoring to ensure that as it is free, so it is served to the people?
Well, we have monitoring and evaluation officers in all our health facilities that offer HIV testing and counseling and treatment. Like I said, we have a toll-free line, 6222. People can reach out to us, lodge their complaint, and then we go investigate. Of course, that's why we work closely with SACAs and LACAs and even network of people living with HIV/AIDS. They have been very competent. They have what we refer to as community-led monitoring of some of these services, and they give us the feedback, and we work using that. So these are some of the ways we have been using, to monitor some of these services. And also to reiterate, when we talk about access, just to buttress what Esther said and so many other people, stigma and discrimination is still a key reason. For instance, I'm HIV positive, my child is positive. Children, you give them drugs, they go to school and they say, oh, my mom is HIV positive, I'm also using HIV drugs. The mother doesn't want that. Perhaps the father does not even know she's negative. We have discussed down couples. Some women are positive and they've not even disclosed to their partners. So when they start giving the children drugs, the father will ask, what is it being treated for? Why these daily drugs? And the mother is trying to shy away from them. The grandma is asking, why are you giving this child drugs? So until we embrace that HIV is here with us, until we embrace that, like any other disease like hypertension and diabetes, and we encourage people to use their drugs, and we encourage people to disclose them, then people will be free to access these medications and to use it. A child is using drugs in school, the teachers are complaining. To emphasize and to buttress the point, you cannot contract HIV by staying in class with anybody. You cannot contract HIV by sharing offices with them. You cannot contract HIV by hugging them and by shaking hands with them. You can only contract HIV through sex, through blood transfusion, from mother to child transfusion, of course, but sharing sharp objects and very sharp objects. And even if the person living with HIV bleeds, if you do not have an abrasion or a laceration or a cut, that you would not contract the HIV. So we have to embrace it. And that is why we have this prevalence of new infection, because people are, and then I must emphasize the ABC of prevention. We keep saying prevention is better than cure, and it is indeed cheaper than cure. So we have to encourage our people. Abstinence is key, particularly for underage. Stay away from sex. Abstain from sex. If you have to use sex, be faithful. If you have to have sex, be faithful to one partner, and if you have to have sex, use condoms. That's a C. Use condoms, don't have casual sex. And of course, the D now is drugs. A huge population of our youth are now engaging in illicit drug use. And that, of course, will lead to disinhibition and very risky sexual behaviors. And we're having very huge population of new infection from this category of people. And therefore, we're saying avoid drugs and, of course, don't shop.
Are you working with the Ministry of Education just so that, the children in school are properly educated?
Yes, we are. We work with the Ministry of Education, Ministry of Health, Ministry of Women Affairs, Environment. We actually have sister agencies, even the law enforcement agents, agencies. We are quite, working with them. Even the Judiciary, the Gender and Human Rights Commission. We are also in touch.
All right. Thank you very much, DG. Let me get to Esther as we begin to wind down this conversation. Now, apart from medications, what would your advice be for people living with HIV and AIDS in terms of keeping fit, diet, and all of those? Because they all work together.
Yes. Looking at a person living with HIV and AIDS, he's not actually sick, which he can live a normal life. Yeah. So exercising is key for everyone, especially once you are aging. You need to keep your health, steady. And then for somebody that also is on medication, exercise is key because sometimes it helps you to digest, to detoxify, and also to keep your system running, like your blood pressure and other things. So to keep you away from all these other underlying health factors, you need to keep fit as well. And then talking about dieting or nutrition is really key because when it comes to adherence, especially with HIV, it boils down to our immunity. So for you to keep your immunity, in check, you need to eat very well and then rest very well and also exercise at the same time because to boost your immunity and then to adhere to your drug because the main thing is not about taking the drug but adhering to the drug to ensure that the drug is working. So you need good nutrition, you need good, exercise, and also need to rest well so that your medication will be effective on your body. So talking about drugs and everybody, not only for HIV, I believe that all of us need nutrition at one point or the other to ensure that when we are taking drugs.
But I want to believe that there are kinds of foods that could help you, improve immunity, help you improve the nutrients that you need to keep going.
Well, it's all about a balanced diet because when you talk about it boils down to everybody where we need it. You need to eat foods.
No specifics for.
For HIV, there's no specific, but you eat a lot of good fruit, a lot of fruits, and especially water, because when you take drugs, you need to take a lot of water to help the water, to melt and digest in your body. And every drugs we take are usually have some certain percentage of toxicity in our bodies. So when you take a lot of water, when you take your drugs, ensure that you take a lot of water. At least a glass of water to go down.
Are there side effects to the medication?
Of course, there is no any drug that doesn't have a side effect. And of course, ARV drugs have side effects. So, and then because even in taking them, we have had drugs before that also affect our, our blood, where they make somebody anemic, which has been changed based on, research. And we found out that some of these drugs, when people take it, they become anemic, like stavudine before. It has been changed. So there are drugs that ever have side, but there are some that when you take it, it gives you, insomnia. So they all have different. But before you are being given the drug, you are always counseled and you are being told the side effects so that you can now watch them. If you happen to manifest some of this, you have to report back to the clinic. Okay. So taking a lot of water is good, and then taking good nutrition like fruits is good for our body and for our eating protein, carbohydrate, foods that we know that will help us. We don't go take excessive food but take balanced diets that are balanced. You need nutrition, you need protein, you need carbohydrate, you need minerals, you need vitamins, especially when it comes to, looking at, we need to work on our nutrition.
All right,
and then our healthy living.
All right. Dr. Daniel Joseph, as we begin to round off the conversation now, what do we need to do just so that we can treat HIV like we treat other ailments, such that someone can say, like you say, I have diabetes or I have hypertension, you can say I have HIV and then be treated as the next person?
All right, thank you very much. That boils down to the stigma and discrimination, right, that is very rampant as regards HIV. I think our legal framework in the country is somewhat weak, right? That's why some of our patients at facility level find it difficult. I'll give an instance. I can't be your neighbor and you are a nurse working in a facility where I'm assessing ART, and probably we are not in good terms, right? And I want to go to that same facility where you're working and assess care, because I obviously know you're going to stigmatize me and discriminate me. So people, until they are, there is a robust legal framework that we have these laws, but I don't think they are really strong, just to say. So people find it difficult to effect it. Assuming I'm discriminated, where do I go from there? Yes, if I walk up to the Justice Department, Ministry of Justice and all that, sometimes it just dies down along the drain. Nothing is is done. So until those laws are robust, they are should I say adapted to fit the situations, and then maybe we have cases where people really come out of it and say, yes, I think I was able to win this case against discrimination, and then people begin to know that, yeah, discrimination or stigmatization is not the way to go. Then people, we get to normalize it over time, that HIV is like every other disease. HIV is not even the worst of diseases. We have quite a whole lot of, but I think, sorry?
I agree with you. I agree. I think it's largely because the way HIV was introduced, of course, everybody said is through sexual transmission. And I want to believe that even to date, it is still the major, source of contracting HIV. So I guess that's why the stigma is there, but a lot of work has to be done in terms of education, even before going legal and all of that. But DG, bearing this in mind and others, what are the key priorities, for Nigeria's HIV and AIDS response, say in the next 5 years?
Well, I will take you up on that, and I want to also advocate for the media to help us in this fight and in this education. We need to create the necessary awareness. We need to inform our people, educate them on, like all that we've been discussing, the route of transmission, contracting HIV. So we need to create the necessary media awareness, and it's part of our priority to create the necessary media awareness. Part of our priority is also to pass the message of prevention across, because as we speak, like I said, the prevalence of HIV is about 1.4% of Nigerians. So that means that at least over 98% of Nigerians are still HIV negative, and we want it to remain like that, or even better. So the key issues of key messages of prevention is key, and we want to continue to chalk that out and churn that out and tell people how to remain negative. So that's also our priority, and of course improving the primary health care. Like we said, we have a sustainability agenda to integrate HIV treatment back into the primary health care. Yes, in many states and many across the federation, we have a private system, like Esther alluded to. You have the specialized clinic for HIV, and then everybody is trying to say, once you enter into that clinic, it's just HIV. But now we want to integrate it back into the main PHC system, so that you can just go for malaria and as well as pick up your HIV drugs. And this is ongoing. We're trying to do this as a government.
Are you doing anything as regards to those living with HIV to protect them? And like Mr. Joseph was trying to talk about, Dr. Joseph, doing something to strengthen the legal framework, just so that they get
yes, like I said, we work with the Ministry of Justice. We work with Gender and Human Rights Commission. But how it is in Nigeria, until you make a case, we don't know you have been discriminated against until you make a case. When we make a case, we take it up. But people don't like going to court and all that. But aside from that, for instance, periodically, we do what we refer to as the discriminatory index. We have this survey about, what do you call it now? Stigma index survey. Trying to see where is the prevalence, where are the hotspots, where is it what across the federation, and this guides us in our policy formulation and implementation. And like we said, we're also working very closely with the network of people living with HIV/AIDS, and sometimes they give us some of this feedback, and we go there. And there's even a workplace policy, in place. Implementation is key. But if you don't make if you don't come back to us with some of these findings, we may not be able to take the necessary action. But if you do, there are actually penalties, as jail terms, fines. It's actually in our laws, and many of these are actually domesticated even at the state level. But implementation is the key.
Now that you're on board, are we going to see more testing taking place?
Yes, I can assure you of that.
All right.
But I must say the HIV is not a solo game. I'm not doing it alone. Like you've seen, we're working with the SACA states, we're working with the local government, we're working with people living with HIV/AIDS, we're working with implementing partners, we're working with international donors, US government, Global Fund. It's a huge space. We're working with civil society organizations, non-governmental organizations across the 6 states of the Federation. And of course, we are working with the media. I want the media to work with us.
Of course, we're working with you. That's why you're here right now. And I'm sure you had a great time. So we also hope that, you will do the needful in your space, and then let's deal with HIV once and for all. It's time to go. Esther, you want to say something? 15 seconds.
Yes, just to say that also we need to promote the community initiatives like the community-led monitoring, because that is the only way we can get feedback from the community, because it is the community that identifies the issue and reporting it. So we can have data on issues, and then we can help that also to improve our response. That is key. And also allocation of funding. We are counting on you, DG, to ensure that increased funding, domestic funding, not from the foreign. But our own domestic funding. We need that also to ensure the sustainability for the rest of
All right, thank you so much, Esther. Esther Hindi, National Coordinator, Association of Women Living with HIV and AIDS in Nigeria. Many thanks for being our guest.
Thank you.
And yes, we hope that you continue to, increase awareness within your space. Dr. Daniel Joseph, Program Manager, Technical Adult and Pediatrics, HIV, Institute of Human Biology. Many thanks for being our guest. And of course, we also want to appreciate Dr. Usman Bashir, Director General, Kano State, I think that should be the Director, Kano State Agency for the Control of AIDS. Thank you so much, Dr. Usman Bashir, for keep up the effort. And finally, thank you so much, Dr. Temitope Ilori, Director General, National Agency for the Control of AIDS, NACA. Yes, I'm sure NACA will return to the lips of many now that you're there, and we wish you all the best. All right, so that's Good Morning Nigeria this Friday. Thank you so much for watching. Take care of your health. I'm Ian John.
And I'm Victor Azo. Do remember, HIV is real, and so that you can avail yourself the opportunity of the World AIDS Day, which is on December 1st, to know your status if you already did. I don't know that. Have a great weekend.